Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Jennie Berkovich, board-certified pediatrician and director of education for JOMA. My guest today is Dr. Sarah Cohen, who is a board-certified pediatrician at Prism Spine and Joint, where she specializes in care for patients with hypermobile Ehlers-Danlos Syndrome and related conditions, including dysautonomia, such as POTS, and mast cell activation syndrome. This interest stems from her own lifelong experience with these conditions. After graduating from Sidney Kimmel Medical College of Thomas Jefferson University, Dr. Cohen remained at the affiliated Nemours Hospital for Children, where she was awarded the Pediatric Academic Excellence Award for Outstanding Research, Education, and Advocacy in General Pediatrics for her work expanding the advocacy curriculum for their residency program. Dr. Cohen is passionate about breaking down barriers to healthcare and education by providing children with appropriate accommodations so they can thrive at school among their peers and mentoring students with disabilities. We had an incredible conversation about Dr. Cohen-Solomon's personal experience with dysautonomia and hypermobility, as well as the work that she does caring for and advocating for these children. I hope you enjoy. Hello, Dr. Cohen-Solomon. Welcome.
Thank you so much. Thanks for having me.
I always say that I'm going to move away from having pediatricians as guests on the show, but it's what's most comfortable for me because I like talking to my own people. So I have yet another pediatrician here as a guest, but you work in a very different type of setup. So tell me a little bit about the type of practice that you have.
Absolutely. So first of all, pediatricians are obviously who you should have on the show.
Agreed.
So I am also a general pediatrician, but I work in a private practice in Silver Spring called Prism Spine and Joint. And the focus of the clinic is really specific. Primarily, we help patients who have hypermobile Ehlers-Danlos Syndrome and other hypermobility syndromes. And along with that, often are what's called comorbidities or conditions that go along with it. Which often includes forms of dysautonomia. And I'll be happy to explain what that means. But in general, my patients have a lot of complicated symptoms. So I have very long appointment times because of the nature of the practice. So I really get to know my patients really deeply on a level we're not usually granted in general practice, unfortunately, but it's a real blessing for me. And my patients just, their symptoms are so widespread that we have a lot to do. So it's really a very meaningful practice for me. And I see patients personally up to age 23, but the practice in general sees all adult ages as well. So it's pretty varied and pretty exciting.
How did you get into this type of practice?
Part of it was fate and part of it is a funny story. So the fate part is that I myself have hypermobile Ehlers-Danlos and some of the complications as well. And I'm pretty public about that, largely because I feel it's gotten misrepresented a lot in media by accident, despite best intentions. So I'm happy to be someone who can explain that, this is my experience, but it's not the same for everyone. So I started being a little more vocal during training. And then when I finished training, I got married. My husband had a job for 3 years, a postdoc in Canada. And I had always enjoyed complex patients in general. And I had a lovely job offer up there. And then the red tape of getting licensed in Canada just for 3 years did not work out as we were expecting to. So the fate part is that just as I was starting to panic a little bit about what I would do for 3 years as a newlywed in a different country, my now employer, Dr. Alyssa Zingman, actually was in the news in the Washington Post because she also has hypermobile Ehlers-Danlos and a lot of complications. And she created the practice with these patients specifically in mind, sort of in answer to what she herself did not find out in the general medical community when she was seeking care for herself. So she created this practice based on that gap. So of course, as soon as it hit the news, every friend who knew about my own experience was like, you have to go make a new friend. So basically I reached out over social media, long story short, she said, hey, let's set up a pediatrician position. I think that'd be really helpful. So I've been working, going up and back from Canada to Maryland for the last several years. Yeah, and it was meaningful enough that it was worth it, but I'm really thrilled that we've just moved to Silver Spring. So I'm now able to be in the clinic every day, which is fantastic. So that is the long and short of how I ended up in such a niche situation.
You mentioned that you think there's a lot of misconceptions or misrepresentations for Ehlers-Danlos and dysautonomia in general. What do you mean by that?
Well, so until very recently, the hypermobile form of Ehlers-Danlos has been considered to be rare. And just to be clear, Ehlers-Danlos is an umbrella term, I like to call it. There are 14 types that we know of, and they're all connective tissue disorders. But the hypermobile type is the most common. Some of the other ones are really truly 1 in a million or 1 in several million. But the hypermobile type, we now estimate between 1 in 200 to 1 in 500, which is not that rare. So unfortunately, as physicians, we're often taught not to expect the conditions that are rare to walk into our office. And so we don't think of it and we don't look for it. So as a result, these patients have often been dismissed unintentionally as either making up their symptoms or no, that can't possibly be because it's what we call medical zebra. It's the term we call a rare thing that we're not expecting to see. So patients have ended up with subpar care. And really suffered as a result. But what the media tends to pick up is either the most complex who are truly suffering, without getting care, like spinal surgeries and feeding tubes and things like that. But there's a whole spectrum of, yes, that is true, but there's a whole spectrum of how people present because the connective tissue is all over the place. So all of my patients have individual life experiences, and that can be hard to recognize and expect when we're looking for this condition as physicians. So it gets hard to manage expectations when, there's so much misunderstanding around the condition. Thankfully, we're getting to a better place where people understand it a lot better and research is improving. So we have a lot that we can do to help both Ehlers-Danlos and the comorbidities, the conditions that go along with it, like dysautonomia.
I think one of the struggles that I have, and it's a little bit of a struggle, and I think just a little bit of a bias that many of us have from training, is that because of the amount of variation that is included in the clinical presentation and all the different types, right, of hypermobility, that I think that the bias piece is that I often find patients sort of label themselves as being hypermobile or having dysautonomia, and the constellation of symptoms, again, just because it's so variable, I think we sometimes tend to call the diagnosis into question, like, is that really what's going on, right? Because it's not like a clear thing, right? Somebody has pneumonia, that's a clear thing, right? Somebody has asthma, that's typically a clear thing. This I find less clear.
Yeah. I think that's a really valid concern. And, any good physician should be double checking themselves and, not just making assumptions or jumping to conclusions. So that's where we should all be starting, right? What's really interesting is that, so because our clinic is fee for service, we help to get reimbursement from insurance, but we have very long appointment times up front for that reason. But as a result, the patients who come to me are really very much at their wits' end. So it's a very self-selected group. And what's really fascinating is that people really are able to use internet resources and social media to get to pretty accurate conclusions. There are very few patients who come to me having been through this journey of almost self-identification that you mentioned, who are wrong. They are almost always right. And in fact, the very few patients who in general, the patients who I've noticed are not symptomatic are the ones whose parent has the condition and they just want to make sure that they didn't pass it to their kid. So they're checking early. And I end up being able to reassure them, which is fantastic. But honestly, I think because, the early days of the internet were not super reliable. And certainly, just to be clear, there's a lot on the internet that is not reliable. But I think this generation is better than we think at figuring it out. and being able to realize, wait a minute, my joints are moving like that person. And there are professionals like myself and like, for example, Dr. Courtney Gensimer, who's a PhD at Medical University in South Carolina. She's a major advocate for research that she does herself, but has the condition herself. So people like her, for example, are excellent resources to show and demonstrate what the condition really is. And people can find that fairly easily. And I think use that to find their own answers before they find a professional. So because resources have changed so drastically since we grew up ourselves and trained, it's really, really key to not discount how well someone can research this before coming to us. Because the danger is then we dismiss them and they don't get the care they need, right? So, and there is a middle ground of saying, look, yeah, there is some of these symptoms. I'm not certain. Let's search more together. Let's learn together. I will see if I can find an expert nearby or learn more myself so I can do a better job evaluating. But in the meantime, here are some best practices that I have found and can help for now so that we continue to support the patient without making the wrong diagnosis up front, for example.
I think that's really important, and I think pediatricians in general are often in a unique position where we kind of just have to trust what the parent is relaying. And I always say, right, the parent knows the kid best. So even if it's not something that we are observing either on our exam or in the history, if the parent is concerned, I always think that's enough of a reason for us to pause and consider it. You mentioned in terms of hypermobility, it's a huge variety, some on the zebra spectrum, right, a less common spectrum, and some of the most common, more common variety. Tell me about if this even exists, like a typical Ehlers-Danlos presentation. How old are they usually, and what are like maybe some of the first red flags that make either the patient or their family pause and say, wait a minute, something isn't right?
Absolutely. So that's a really important question. And the answer as far as age is that really any age. Historically, we haven't had our eyes on the youngest kids yet. So it's hard to say because the research is really new. For me, one of the major symptoms that I hear from families on the younger end is that they can't keep up with their peers. And that might just demonstrate as just not being able to hold up in school, in class. So the other kids are making it through the day, getting home, doing their homework, not having an issue. And this kid can't get through the day without going to the nurse's office to lie down. They're squirming in their chair. They're uncomfortable. Gym class is giving them aches and pains, things like that. And that's
And are they, I'm sorry to
Yeah.
interrupt, are they not able to keep up because of what's the actual issue? Is it fatigue?
That's a great question.
Pain? What's
It
the
depends on the
limitation?
kid. My theory is that it's a little bit of a combination because it's really hard. If you've never lived in another body, it's really hard for kids and adults to describe these symptoms because it's just your entire lived experience until you start learning the lingo.
Yeah.
So for the youngest kids, I think the joint instability is causing both pain and fatigue because it takes a lot more effort for your muscles to do the job that they're not supposed to be doing. You're supposed to have connective tissue doing its job, muscles doing the support. And for the muscles to have to do both, it's exhausting. It's really fatiguing and it hurts. So these kids are like slowly but surely just not making it the way their peers are. And the parents are often looking at the park and being like, my kid is, I don't know, not keeping up with the other kids. They need more breaks. They're tired. And it's not directly like a breathing issue, like they're huffing and puffing. It's hard to put your finger on. And that's part of what makes it so difficult to see early on. But as they grow up into teenagers, especially around adolescence or after an illness, my theory is it just sort of knocks the system out. So whatever you're compensating with, you just lose. So either it's the hormones changing or some illness or an injury or something. And not for everyone. Some people, the symptoms just progress, but for a lot of patients, there's an event that just changes how your body can manage. And all of a sudden or slowly, your symptoms are now unmanageable. So now you've got pain. Your joints are, I like to say, loosey-goosey or like Laffy Taffy. So you don't necessarily see the classic dislocations, although I'll tell you, I've had some patients on my examining table who, while I'm looking at them, a shoulder will literally just drop out of place visibly and we have to put it back. Like that can be as bad as it gets. But for other patients, it's just a vague sense that when you move, things don't stay where they're supposed to. And it's like being Rice Krispies, you're snap, crackling, and popping all over the place. And by the end of the day, things are tired and it hurts and it feels like you have to hold yourself together. And that is literally true. but it's really hard to put language to that until you've heard someone else use that language. So that's part of what can be misleading, that, oh, they're just learning it from social media. No, they're identifying, wait a minute, that's how I feel. But I've got to tell you, I get home from the clinic and have to sort of rewire because it is my lived experience. So I'll ask my husband, sweetheart, do you ever feel like your shoulder is not where it belongs? He'll just look at me and laugh, and you're like, are you recalibrating again? I'll be like, yes, I am. He says, no, I can't feel my shoulders dislocating. My knees stay where they're supposed to. Nothing feels like it's falling out of place. When I point at the door, nothing feels like it's popping. Like it's a whole conversation because it's a different operating system at the end of the day. So it's hard.
It must be so validating for people who have the condition to hear this description and to hear others put right language around something that they've inherently been feeling, but maybe was being dismissed. I find that, and I don't know if this is true or not, that it's not a diagnosis that we really have. Let me start that over. I find that it's a diagnosis that we find later in life, right? Not, and even you said yourself, right? There's not a lot of research for younger kids. And so I often hear of it being diagnosed in maybe early adolescence or young adulthood. Is that the case? And if so, how are those symptoms manifesting later on in life?
Great question. So, as a matter of fact, just last year in 2023, there are new guidelines for diagnosing in the adolescent and childhood population. So those guidelines can be used from age 5 until skeletal maturity, or 18, whichever is first. And what I really like about the updates is that they make it, and I'm sorry about the pun, somewhat flexible as a diagnosis. So the idea being that not everyone is going to present the same way, and certainly not when they're very young. So at least we get eyes on the problem. You know, we can watch and say, okay, yes, you are extra flexible and you have some of these symptoms. We're going to put you in this category so that we can monitor, get you some good treatment, physical therapy, pain management, all the other things that we need. But we have eyes on you now. So if and when it changes, we'll see it before it's a big problem. What I don't fully agree with professionally is that in an effort, and I think this was valid, in an effort to make sure we didn't overdiagnose, the recommendations are not to give the hypermobile Ehlers-Danlos label until you're skeletally mature. But in my experience, and I have checked on this with other international professionals who I won't name drop, but who are really enormous names. If you already meet the adult criteria when you are younger than skeletal maturity, there's really no data to say that you're going to grow out of that. So for me, I will usually have both forms in front of me and fill out the pediatric and the adult criteria and see where that gets me. And at the end of the day, I'm going to give them the diagnosis that will help them most to get the good care and that I feel fits what's in front of me. So the adolescents, once you're sort of 14 and up, I start seeing a lot more injuries, a lot more pain, a lot more skeletal dysfunction in that maybe you have dislocations, but maybe just everything is a little misaligned where like I can see them sitting in a position where like they're just sort of twisted around. You can see that they're uncomfortable. There are maybe muscle spasms in places that we don't expect. And they're struggling. And that's also when we start seeing some of the additional comorbidities a lot more. So things like POTS, which is a form of dysautonomia.
I want to ask a quick follow-up question. We're sort of using Ehlers-Danlos and hypermobility interchangeably. Is that okay to do? Are there other
No,
types
it's really
Oh,
not.
no, it's not okay.
Yeah.
All right. So let's use appropriate language. Like, so what, there's other types, right, of hypermobility. Is that because they just don't officially fit the ED criteria?
No, but that's a really great question, and it's a question I get a lot. So a person can be hypermobile, which means that their joints go too far without actually being unstable, and without having a true connective tissue disorder. So there are definitely a lot of dancers and gymnasts and just people walking around day to day that have some form of, quote, hypermobility. And the hypermobility might be general, where you fit what's called the Baton score, where you have an overall general hypermobility in many, many joints. Or you can have what's called peripheral, so just hands or feet, or just one joint or another. And those are just the measurements that a physical therapist or a physician can record and say, yes, you are hypermobile. If you don't have any other symptoms and you just happen to be flexible, That's just pure generalized or specific joint hypermobility, and it doesn't affect you medically per se. But once you start having pain or repeated injuries or other like soft tissue findings, for example, like there's a super, super soft, velvety or silky quality to the skin for most of my patients. Certain types of scarring where the skin either rips too easily or does not scar correctly. Those are the kinds of things that I start saying, okay, now we're not in the general no big deal, you just happen to be flexible category. But then there are, in addition to the Ehlers-Danlos conditions, there are other conditions like Louis Dietz and Marfan's where people can be extra flexible, but because of different connective tissue underlying structural problems, those can come with other issues like hearing loss or valve and vessel problems, we'll just say, you know, and it's really, really important for a physician to make sure it isn't one of those things. And that's really where the challenge for a physician comes in. It's not hard once you know how to do it, but that's the important part to make sure we don't disservice the patients.
Things like vessel issues, right? Valve problems, right? Things, you know, the aortic issues that are associated with Marfan's. I feel, again, just from like a medical standpoint, very clear cut, right? Obviously, you have to know to screen for it. You screen for it, you have it, you don't. That's kind of it. Other dysautonomias, right? Or symptoms dysautonomia, I feel like are a little bit fuzzier.
That's because they are. So dysautonomia is a huge category, and I'll just break down what it means for listeners. So dysautonomia, first of all, the autonomic nervous system is part of your body's just autopilot controls. So anything that you shouldn't have to think about for your body to function, breathing, heart rate, blood pressure, temperature, your pupils getting bigger or smaller, digesting food, going to the bathroom, all of these things should be relatively on autopilot. Obviously, some of it is somewhat under our control. Like I can hyperventilate on purpose and then get my breathing rate up, but most of the time during the day, I'm not thinking about taking a breath. That's on auto. So that's your autonomic nervous system. It has two sections, commonly referred to as the fight or flight and the rest and digest systems. They're both the autonomic nervous system, but they balance each other out. So you shouldn't be in fight or flight, also called sympathetic nervous system mode all day long. That would be like having a panic attack all day because you're constantly fight or flight. Rest and digest, on the other hand, obviously we all need to recharge. That's the parasympathetic nervous system. So all of that is under the autonomic heading of the autopilot system, and any of it, I know this sounds dramatic, but any of it at any point can go wrong. And the broad term dysautonomia refers to anything in that category that has gone wrong or isn't under good control anymore. So, you know, we think of it as kind of fuzzy and hard to detect because it is. That's a really broad category. So for me, what I start thinking about is if they are fatiguing more than I expect just because of the joint pain, or they're specifically fatiguing from standing up, or they've changed their life. So for example, a young adult never goes to the grocery store. They only get their groceries delivered because who wants to stand for that long? Or, you know, they find activities, for example, that are less about active outdoor play and more about art and music and sitting still inside. Obviously, that's not a bad thing in and of itself. You know, I was an art kid, that's okay. But if it's because they're avoiding standing up or activity or getting too hot or getting too cold, why? Because their body is too sensitive and not responding correctly, then we start going down this pathway of, hey, is it the autonomic nervous system? And the good news is there's actually a lot that we can do to make that better. And we don't, you know, that's a sort of new-ish knowledge. So not everyone realizes just how much we can do to make life better for people who are suffering from those symptoms. But that's the good part. That's the happy message.
How do you go about this investigation? So let's take one of the, I guess, more concrete diagnoses of POTS, right? POTS,
Yeah.
I believe, right, has a little bit of like clinical criteria to it, right? There's some testing that we do. Again, I think one of the more challenging diagnoses for people to make because it's less concrete than something else. And that's the more concrete one, I think. Right. So tell me how from your end, like you even go about initiating and confirming these
Absolutely.
symptoms.
So for me, because we know that POTS and dysautonomia is so common for people who have Ehlers-Danlos, I get a little bit of a leg up where I'm always keeping an eye out for it. So that makes it much easier for me. But certainly if a patient, in the general a pediatrician's office is like out of school a lot for kind of vague symptoms, it's reasonable just to keep it in mind, rule it out before we assume that it's something like, school avoidance just in and of itself. Because school is your whole day and it's super exhausting for these patients. So I always think about that if they're just not keeping up by the time they're in high school. Because as it turns out, none of the teenagers want to be the odd one out. So if they're out all the time and something's going on, like there's a reason. Anywho, so for POTS, so POTS stands for postural orthostatic tachycardic syndrome. And the literal definition of that is when you go from laying down to standing up, your heart rate goes up too much. So depending on which paper you want to look at, either under 16 or under 18, we say if your heart rate rises by more than 40 beats, that gives you your diagnosis within like the first 10 minutes of standing. If you're above those ages, we say 30 beats, or if your heart rate with standing is above 120, just because you're standing. Now, obviously, we want to make sure that a cardiologist has double checked that there isn't a different heart problem going on, like an arrhythmia, for example, where there's a problem with the beat itself. So, I always have all of my patients just see a cardiologist up front. So we get some imaging and what's called an EKG to check the rhythm, because I know that I am not a cardiologist. So I don't want to miss something. So we double check. But I can do a POTS screening myself. And all that is what's called a 10-minute standing test. So I have them laying down for 15 minutes. We chat, we try to keep it chill. And then I stand them up. And for every minute for 10 minutes, I get heart rate and blood pressure, and we see what we get. What's really important to understand, though, is that your heart rate and blood pressure might not give me the information I need that day, because every body is different and being in the doctor's office is different. So we might have to repeat it, and that's okay. So if you're really uncertain that, a previous test was maybe wrong, it's okay to ask again on a different day. You might have been dehydrated that day, or really well hydrated that day, or your sleep or different medicines. Like, it's okay to double check in case it's not right. But in any case, once we get these numbers, there's a lot that I can do in terms of medication. Keep in mind, though, that having the diagnosis of POTS doesn't tell me why it's happening. So again, that's why I check with the cardiologist, just to make sure it's not, like a supraventricular tachycardia, for example, where the node in the heart is telling your heart to beat too fast. We fix that a different way, and that is a cardiologist's department, not mine, and that's okay. But in any case, POTS can happen for lots of different reasons. It can be related to autoimmune conditions, like Sjogren's, for example, is the most common reason for POTS, but sometimes there's no other underlying reason, and that's okay. We treat the symptoms either way. But it's good to keep that in mind, because it's a question I get a lot, like, what is the cause? Sometimes we do not know. But we can make it better anyway.
So I am impressed by the amount of clinical criteria and I'm sure very thorough physical exam and investigation, right, that these patients go through. I think I'm also impressed by the idea of how much dysfunction there is that, like, you kind of have to adjust and live with. You mentioned, right, people, avoiding being active or avoiding going to the grocery store. I imagine, right, that can extrapolate to really limiting your life. So the treatment is very, very, very important. Tell me about some of the tools that you have for these patients.
Absolutely. So the first thing is that everyone needs to learn what's called lifestyle modifications. And this is often a tough conversation, because a lot of the time when people don't know, or when physicians aren't familiar with the medications, they stop short at lifestyle modifications and leave it there. They're important, but they're not the only thing. So I like to emphasize that with patients. So first and foremost, we want 2 to 3 liters of water in a day for our adolescents. And it is weight dependent. We don't want to overhydrate the little guys. So, judgment call there. But we also need a heck of a lot of salt, because we don't want to overhydrate and not have salt to help with the absorption and the balance in the body. But people with POTS and dysautonomia, especially when it's related to Ehlers-Danlos, for not totally clear reasons, don't fully absorb water very well through the gut or hold on to it in their vessels very well. And that's an area of ongoing research, but that's part of why it's really important to almost overload, not truly overload, but have all that salt as well that can help We also want to make sure that patients are familiar with garments like compression socks, which are basically, usually they're a knee-high sock with extra stretchiness, so it helps the blood flow return to the core of the body and to the heart so that it flows a little bit better. There are compression garments that you can wear all the way up to your stomach, on your abdomen, and those can help, but they're not right for everyone depending on your other conditions. So we review them, and usually I tell patients to just try a few, see if they help. It's good to have different things to reach for on different days because you might not feel the same every single day. So we have that conversation. It's also important to take what we call at Prism horizontal breaks. So just a period of the day, usually I say every few hours, just lie down, lie flat for 15 minutes, give your body a break from working so hard to get the gravity of your blood all the way to your brain. Make it easy for your body for a few minutes. And that can really help to recharge and keep your symptoms under control. Some people find that if you put cinder blocks or some other way to rise your mattress up from the head, so your whole mattress is on a slope, if you sleep like that for several months, it can actually help to reset what's called your orthostatic tolerance, or basically the symptoms when you stand up. That's what orthostatic intolerance means, that you have symptoms when standing. And I don't think anyone totally knows why that works, but for a lot of patients, it actually does. So that's really good to know. Once we get into medications, we are aiming for controlling the heart rate. And for some patients, their blood pressure will go down as well. So we'll try to keep their blood pressure up or steady. Some patients start with high blood pressure, so we want to keep that low. And that's when it becomes, a little artistic and trying to make things balanced. But also we want to help the volume stay up. So one of my favorite medications is called Florinef. That's the brand name, or fludrocortisone. That's usually where I start. Since my patients are young, they usually have no kidney problems, but it is good to double check that what's called a BMP, or basic metabolic panel, your physician can order, and make sure that your kidneys are working beautifully, because this medication works on potassium channels in the kidney, and basically helps water to stay in the body, so that your blood volume is higher. Because one of the main features of POTS specifically is that if you picture your body as a big cylinder, while you're lying down, your cylinder is flat, the water or your blood is all, spread out, it gets to your head just fine. But if you lift that into a vertical position, all the water falls down. So your kidneys, which are lower down, are going to experience extra water, whereas your heart and your brain think you don't have enough water. So your heart is going to say, oh, we've got to kick up our heart rate so we get blood to the brain so you feel better. But that high heart rate feels awful. And that's why a lot of patients think they have anxiety or are diagnosed with anxiety, because it is literally a symptom of anxiety. Your heart rate is up, your head is not getting enough blood flow, and it feels awful. But your kidneys are saying, wait, I have too much water, I got to pee that out. So now we have an imbalance working really hard to make it all connect. And if your blood pressure can't keep up, it drops and you faint. And that is not good. So that's also where injuries come in. If you hit your head, that's no good at all. But if we can trick your kidneys with Florinef into keeping water in, that's a major way that we can keep the blood pressure up, the heart rate down, blood flow going to the brain, just by getting that volume up. So that's my favorite trick. Starting with Florinef is really effective for a lot of patients and really easy to prescribe. It's one little pill a day.
You mentioned anxiety, and I feel like we can't have a conversation about dysautonomia without addressing the mental health
For
piece
sure.
of it.
Yeah.
Right. So I think, again, a bias and misconception is that these patients are often written off or dismissed as these symptoms being exclusively due to mental health challenges. But I find, and you can tell me if this is correct, that the opposite is true, right? The anxiety and all of that develops as a result of having to live like this.
Yeah, I couldn't agree more. So one thing I like to say is, look, you're entitled to as many conditions as your body decides to have. Like, unfortunately, there's no limit. So I don't want people saying, oh, they're only allowed one condition, but you're right.
We like for things to fit in a box, right? We like for
Yes.
all the symptoms to put one box of one diagnostic box.
Yeah, and
we
that's how
don't
we're
like
taught.
we don't like a second box.
Oh my gosh, second boxes are so not how we were taught as physicians, and it can be really hard to get ourselves out of that box. But it's also hard for patients to carry multiple conditions as like their diagnosis list grows. That's really burdensome emotionally, especially for the young ones. So I have a really thorough conversation with them about how, look, having chronic pain and having had the journey of trying to figure out the answers is really, really hard emotionally. It's hard for the individual, it's hard for the families. The parents are scared that they're missing something and that something dangerous is happening and something's going to happen to their child. Like, this is a huge emotional burden. And basically I'll make the joke like, look, I dare anyone to go through that and not develop some anxiety and at the end of it. Like, that is scary. That's fair to anybody. It's traumatic. And there is unfortunately a lot of what's called gaslighting, and that term has become overused. But when someone is told that their symptoms aren't real over and over again, or that there's nothing wrong with them over and over again, and they're searching for answers, that is not just disheartening. That can help you. That can cause you to start questioning your own sense of self and your own sanity. So I do have patients who have suffered so traumatically that they have required hospitalization because of how much they are holding. And if that is necessary, if you are having, for example, God forbid, symptoms of wanting to end your life, then you still do need appropriate psychiatric care. Like, we can't ignore what is real in that regard. However, on the other side, if we start telling especially young women, oh, your symptoms are all just due to anxiety, that is a huge problem that we assume that's where the issue lies. We have to be thorough as physicians, and we have to be honest about what we do and do not know, and really look into these symptoms. So it's hard, when your symptoms of a medical condition mimic anxiety, determining the difference. So, if your anxiety only happens when you're standing, that's a pretty good sign that it's not anxiety. That is orthostatic intolerance again. If it happens regardless of the circumstances you're in, and it's always your heart rate racing, these are clues that I start picking up on. Say, wait a minute, like, sure, you might have developed some anxiety, but this is POTS. This is my field. So it's challenging. It's challenging, but it's really, really important not to assume that it's depression and anxiety in anybody. Yes, we have to treat those appropriately. Nobody's saying otherwise, but we've got to do the rest of our job well too.
I love that. I'm sure very, very validating to hear as well. I want to finish up by talking about prevention. So
Mm.
one thing that I always ask my guests on the podcast is if somebody wanted to take steps to avoid being your patient one day, is there anything, right? Is there anything they can do?
Yeah. So that's a hard question because, as we understand it currently, Ehlers-Danlos is a inherited condition, right? So if you get that gene from a parent, or if you get that gene just as a mutation in your own body, like, I can't make that unhappen right now. There are some really cool research, under development that maybe in 20, 40, 50 years, we might have gene therapy. I don't know. But right now I can't truly prevent it, but I can make it a lot better. So if your body can already or can still tolerate movement, keep moving. I want to be super clear that these conditions do not develop due to what's called deconditioning. Like, these don't happen because you were inactive or not exercising. That is
Another common misconception, by the way, and bias,
exactly.
right?
Absolutely.
Because one of the things that I think we tend to think of as a good tool is improving conditioning.
Absolutely.
Right, which I think is accurate, but it's not that
Yeah.
your deconditioned state resulted, right, and you having
Bingo.
dysautonomia.
Yeah, so I'm so glad that you said that. But yeah, so what's challenging is that if someone is suffering so much that they can't exercise and they can't have a body that moves throughout the day, um, that's not going to make your symptoms better. It's definitely going to make symptoms worse, but it's not the cause. And I do want to just point out a red flag called post-exertional malaise. So, and if you are experiencing what people often call a crash, either energy or pain, in reaction to appropriate movement or exercise, and maybe it's an hour later or a day later, but it has you just flat out not able to function, that's called the post-exertional malaise, or PEM. Sometimes for some patients, that's a red flag that you might have something called MECFS, myalgic encephalomyelitis chronic fatigue syndrome. So this is the newer, fancier term. It used to just be called chronic fatigue syndrome, but we now understand that there's more going on in the brain and in the nervous system that needs to be, addressed with an appropriate physician. So if someone is having that crash after exercise, it's important to get that evaluated for, because that needs to be treated a little differently, where you go much more gently with any sort of exercise to avoid the crash. The physiology is different, and unfortunately, it's really similar to long COVID. So I just want to put that red flag out there that usually in like an injury or pain, we go to physical therapy and we say, okay, let's push a little bit. We're going to improve our stamina. That is not appropriate in these patients. And it's really key to notice that before we cause damage. For the patients going back to the hypermobile Ehlers-Danlos syndrome alone, it can be a little similar where we don't want to push too hard and again cause damage because the glue holding the body together is not doing its job properly. So it's easier to injure and easier to fatigue, and we need to go a little more gingerly, but it's also really important to have a team that understands that there might be alignment problems in the body. So maybe not a full dislocation, but patients will often come in and I will realize that their radial head in their elbow is out of position. It's not all the way out, but they can't, what's called supinate, they can't fully rotate their elbow so that their hand points upwards towards the ceiling, and it's stuck there and it hurts, but they're used to pain. And when I can put that back into position and what's called reduce that partial dislocation or subluxation, they're so much more comfortable, but then, I can see that their movement is easier too. So if they are doing exercise or therapy in a body that is partially out of place, 1, it hurts, 2, it's easier to injure, and 3, you're not going to make the progress because you're working against yourself. So we need to have either a physical therapist or what's called an osteopathic physician, anyone who can do careful, key word, careful joint alignment so that you're not working against your body in the first place.
I just want to interrupt. I know because you keep saying body alignment, and what I'm worried a lot of people are going to hear and equate aligning with chiropractor.
Yes.
And you very intentionally did not say chiropractor. So I just want to emphasize that's typically not recommended.
That's a really great question, and it's a little bit hard to answer. So as with any medical professional, you can find someone who is really, really skilled and an excellent resource or not. And the problem is I don't know in advance who's going to be which one. So while there are definitely areas in the US and in the world where a chiropractor is more available, I can't vouch for them, although technically I can't vouch for any physician in some place either. So what we want is to vet the medical professional as best we can. And often going to support groups locally, you can find people who have experience with the local professionals and can give you a little more insight. So what I tell patients is I am not banning the use of one type of professional or another, but rather I'm saying it's really, really important to find someone with a very, very experienced practice. They really know the pitfalls, the risks. I do not want anyone, no matter if it's an osteopath, a physical therapist, or a chiropractor, I don't want anyone doing what's called a high velocity adjustment on the neck. That is 100% no. So that's what people get worried about and are hearing scary stories about with chiropractors cracking the neck and causing vessels in the neck, the arteries to rip and tear and cause truly, truly horrible injury and even death. So that's the big scary. That's not isolated to a chiropractor. Any medical professional who doesn't know what they're doing can cause that risk. So you want to be careful. And unfortunately, there is an increased risk to the connective tissue in people with hypermobile Ehlers-Danlos and any type of Ehlers-Danlos. So we want to be extra, extra, extra gentle. So regardless of who you're going to see, you want to say no high velocity adjustments. Everything needs to be gentle. And, if you're in an area where there is absolutely no physical therapist or physician experienced with what you need, or I should say a physiatrist is often experienced as well, a medical physician called a physiatrist, but there is a chiropractor who is willing to listen and learn and really, really be careful. I'm not going to say don't do that. I'm going to say proceed cautiously and keep the lines of communication open and get me on the phone with them so that we can have a conversation. And the goal is always to get the care to the patients that they need and not to avoid a possible resource, but we need to proceed cautiously with anybody because it's a vulnerable body. Yeah.
I love that answer. Very, very practical. Very practical approach. I really appreciate that. Dr. Cohen-Solomon, I want to thank you so much for your time and for talking about the fascinating work that you do. And I want to thank you for that amazing work and for the advocacy that you do for your patients.
Thank you so much. It's a pleasure to be here. I hope people can learn from this, and we are contactable at PRISM. And we are accepting new patients if people are interested in coming. So
Excellent.
This was great. Thank you so much.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.